Hello, this talk we would like to present our empirical narrative research on the development of a hand surgery curriculum for an underdeveloped country like Cambodia. The aim of this research was to design, develop, deploy, and evaluate a hand surgery curriculum that is contextual to the locality of Cambodia that would provide the basis for sustainable long-term development and empowerment of local surgeons. In keeping with the principles of competency-based curriculum, prior to the development of this curriculum, the needs of the community and the learner was assessed by prior visits to the center by the senior authors of this paper. The learning needs in the communities was then analyzed, and the curriculum was designed, which was competency-based and targeted to the needs of the community. The curriculum was then delivered using technological advances to enable online, on-demand, self-paced learning, augmented with hands-on workshops which were of a flipped nature. By this, we developed entrustable professional activities that were relevant to the community and that were used in improving the quality of hand surgery care. In determining the needs of the community, 600 cases that were operated that were related to the upper limb prior to our arrival were analyzed, and these were the data. By and large, a lot of them were deformities that result from trauma and burns, and with a significant portion of congenital. A small portion of nerve injuries were seen. However, following the visit by the senior authors, the analysis of 96 cases operated revealed a slightly different type and portfolio of cases. Again, trauma and burn deformities were still major. However, a significant amount of nerve and brachial plexus was seen, and this was slightly skewed by the fact that the surgeons started to train the locals in assessing and providing strategies for the management of nerve injuries. Congenital still took a significant portion of the number of cases that were operated. Using these figures, a Pareto analysis was performed on the types of cases seen, and a decision was made to then have a curriculum that would reflect the community needs. And here in this table we see, apart from the generic basic science, deformity correction was one of the major curriculum that was designed, and the learning outcomes included the understanding of flap design, and for this the work-based assessment and work-based training was provided, with assessments being shown as DOPS and mini-secs and CBDs. Deformities, again we had tendon workshops in terms of how to avoid some of the deformities. For trauma, we had fracture and dislocation and osteomyelitis. This was again managed with a workshop. And for nerves and brachial plexus, we had a microneural workshop. And for congenital hands, the teaching mainly consisted of lectures and work-based teaching. Once the curriculum was designed, material that were available on handsurgeryedu.com, an online platform, were then curated for the students to learn as resource materials, and this was then augmented with specific workshops that provided the skill acquisition in a blended format, using the concept of flipped classrooms, where lectures were seen and observed by the candidates prior to the workshops, and assessments performed prior to the workshop to make sure that they have acquired the learning, and then through the workshop skills were transferred. Hands-on assessment was performed either through asynchronous methods using video recording of skills, or through work-based assessment using the DOPS. Based on the curriculum, 4 workshops were performed, and these were the order: a microneural workshop using the foot of the pig, and here we used one of the nerves, and there were 12 microscopes that were available in the hospital, and we managed to get 12 surgeons to undergo a one-day workshop on this repair of peripheral nerves. In order to ensure deliberate practice, the surgeons were encouraged to continue on a weekly basis to practice on the model for nerve repair, and assessment and feedback was performed asynchronously by ensuring that the local technician would record the videos, and which were allowed the faculty to assess and grade them. A flexor tendon workshop was also held, and using again the biological high fidelity simulation model of the tendon of the pig's hooves. The resource materials were translated to Khmer language from the online learning platform and hosted on their own YouTube for the Khmer surgeons to understand the resource material better. To facilitate adequate usage of implant material, a fracture fixation workshop was held with saw bones, and these basic principles of fracture management were taught, and satisfactory response was obtained by the participants. To facilitate the ongoing education and for the sustainability of this project, we conducted an IT workshop to engage the local surgeon in producing educational resource materials in Khmer language, so that these can be then used on their platform for other surgeons to learn as an open educational resource. Generally, the program has increased the knowledge base of the participant and surgical competencies. The stakeholders perceive the program to be beneficial in allowing for effective transfer of knowledge and skills by the visiting surgeon to the local surgeons. A survey was conducted on the perception of the local surgeons on how well the learning program has been and whether it has produced teachers out of them, and these were the responses that we obtained. Our findings from our sample of the surgeons indicate there has been a significant improvement in their knowledge and competencies as a result of the curriculum that was delivered onto them, and they feel confident to be able to teach others. And I think this shows evidence that this program has been effective in delivery of hand surgery education in Cambodia. Thank you.